Well, let's get started. It's 4:30, and I want to respect everybody's time. So this is
Recording in progress.
Recording is in progress. We essentially have a two-part audience today. We have about 50 or so odd people that are online joining us on Zoom, as well as people here in the building with us today. So first I want to thank everybody that joined us, however you've done it, especially those of you that joined us in person. It's really good to see you, and please speak up. We want to make this as interactive as possible. So if we're saying things that are prompting some questions, or you'd like to hear some more about that, please let us know. We'd love to do that. We have two speakers today. I'm the first speaker. Sorry about that. And then we have a really good speaker that's going to be coming up following me, and that's Eric Jackson from Johns Hopkins University. I'm going to start by talking about my research in Chiari over the years, starting at I think a relatively basic elemental level, like what is Chiari? How did we define Chiari? And then getting into more questions of prevalence, natural history, and also some of the big kind of long-term lifestyle questions that comes up with Chiari malformation. And then Dr. Jackson is going to look at Chiari really in a much more granular way, and is going to look at submitted patient questions with Chiari malformation. I think it was the 99 or 100 most common questions that he gets asked about Chiari malformation, something like that. So hopefully this will be a good learning experience for all of us. I do want to thank the Bobby Jones Chiari Syringomyelia Foundation for their very, very generous support of this meeting, as well as meetings like it all around the country. Bobby Jones is a extremely important part of the Chiari environment in the United States. They support research, they support researchers, and they really support this ongoing dialogue that we're all having around the country about these important questions about Chiari. In the back of the room we have Dorothy Poppy, Mary Poppy, who have been doing great work for many, many years in the Chiari world. And Caitlin Esposito as well deserves a shout out. She couldn't join us this year, but I really appreciate Dorothy and Mary getting on a plane and coming all the way across the country to join us from New York today. So Chiari malformation. What is a Chiari malformation? Why are we hearing so much more about it now than our parents' or grandparents' generation? Well, in the old days, this is how you defined Chiari malformation. You'd have to do, these crazy, air ventriculogram, air myelogram studies, and look for the cerebellar tonsils. And it was very hard to do before the era of modern imaging. So Chiari was considered a very rare disease until the era of modern imaging. That all started to change a little bit with the advent of CT scanning. Here's a 1978 paper, essentially a case report of somebody that did a CAT scan and found a Chiari malformation, and they thought that was really worth talking about. But they do go on to say that they think it's very hard to define this even with CAT scanning. Everything changed in the 80s with MRI scanning. And this paper from San Francisco in the 1980s really, I would say, changed everything. This is by Barkovich and others from UC San Francisco. And they came up with this idea that we're all still using today in 2025, which was that Chiari malformation is when you have your tonsils more than 5 millimeters below the foramen magnum. They decided that this was how they would define Chiari malformation in the mid-1980s. And I would say whether we like this idea or we don't like this idea, we're largely stuck with this idea in 2025. I think it's important to understand the basis for that decision, though. They looked at 200 normal patients and 25 patients who they thought were classically symptomatic from Chiari. And then they just asked the question, well, what if we decide that tonsils at the foramen magnum is diagnostic for Chiari? What would our sensitivity and specificity be? In other words, who has symptoms, who doesn't have symptoms, right? And okay, well, that didn't work. What if we go 1 millimeter below, 2 millimeters below, 3 millimeters below, and so on? And when they got to 5, they decided that they had a 92% sensitivity and a 100% specificity. That is to say, everybody with 5 millimeters below the foramen magnum were symptomatic from Chiari. Now, in 2025, we know that's nonsense. And in fact, we've known that's nonsense for many, many years. But this was the paper that really set us on the 5 millimeter pathway that we've all been on since 1986. This was a really good paper in 1986, and I don't mean to suggest that this was bad work from these authors, but we can do a lot better now with all of the data that we have in 2025. 5 millimeter rule that we're all stuck with, I think, leaves a lot to be desired. Each of these images shows a patient with tonsils below the foramen magnum, but you can clearly see that the tonsil shape is very different, with very pointed tonsils on the left, very rounded tonsils on the right. There is the so-called Chiari zero malformation, where you have a very impacted foramen magnum. You even have cervical syringomyelia in the classic description of Chiari zero, but you don't have tonsils 5 millimeters below the foramen magnum. And that's another problem, of course, with this definition. So I try, in my own personal practice, not to get too hung up on this measurement that we all talk about, the 5 millimeter rule. And I think that it's natural for physicians as well as patients to use this because it's simple, right? And when Chiari patients talk to each other, what's your number? I'm a 7. What are you? I'm a 9. But I would argue that it's way, way overly simplistic. But again, in the real world, we're dealing with MRI reports. Our chief of neuroradiology is in the audience, and I think I told him I had some examples of these, which I would show. But here's a radiology report: low-lying cerebellar tonsil, 6 millimeters below the foramen magnum, consistent with Chiari. So, to a great extent, this is a diagnosis that's being made on imaging. Here's another radiology report: cerebellar tonsillar ectopia, 7 to 8 millimeters, consistent with Chiari. This can be a cause of headache or neck pain. So this is what patients are showing up in our clinic with, right? They have a headache, they have this report, and now as a neurosurgeon, it's our job to understand that patient's headache in more detail and understand, is it actually the cause of the headache or not? So MRI has changed everything with respect to Chiari. Again, it used to be a rare disease, now it's a common disease. Essentially, all the data I'm going to show you from now on are from our group. And this is a paper I wrote about 9 years ago, just looking at new Chiari diagnosis in a large privately insured database in the United States, looking at about 30 million patients on a year-to-year basis. And this is not a cumulative graph. This is a year-to-year-to-year graph, just showing that the number of patients diagnosed with Chiari in the United States almost tripled between 2000 and when we studied up to about 2015. We talked about the 5 millimeter rule, and I told you that was an oversimplification. I think the most important thing to understand about tonsil position in human beings is that just like any other measurement we can make in human beings, we get this essentially bell curve distribution, right? So if I look at head size or waist size or weight or whatever, I'm going to get a bell curve with kind of an average right in the middle. And the farther you get from average, the less and less likely that eventuality is. Well, tonsil position is the same thing. So this is another one of our papers, just looking at tonsil position related to the foramen magnum. You can see that the mean, most people are up right around the foramen magnum or slightly higher. It changes by decade in life. And again, this is looking at a data set of thousands and thousands of humans getting an MRI for any reason. And the take-home message here is that our tonsils generally get higher and higher throughout life continuously. But actually, if you look at the lowest tonsil position, that's the second and third decades of life. And that's when people, for the most part, are presenting with Chiari. You can get Chiari symptoms in the first decade of life. You can get Chiari symptoms in the 7th and 8th decades of life, like we see that. But that's all less common than the second and third and maybe 4th decades of life. And that's when you have low tonsils. So tonsil position is not the be-all and end-all. However, it is important. subjectively, we have to decide, is this patient symptomatic from Chiari? Is this patient not symptomatic from Chiari? And at least looking at our data, in this graph on the left, the short bar, this is 5 to 8 millimeters below the foramen magnum, lower and lower tonsil position over to the right. And you can see that the lower your tonsils are, the more and more likely we think you are to be symptomatic. Same thing, lower the tonsils, the more and more likely you are to have syringomyelia. The blue bars are no syrinx, the red bars are syrinx, and the x-axis is tonsil position, and you can see that the red bars are sort of catching up with the blue bar height, lower and lower you go, right? So having tonsils that are less low makes you less likely to have symptoms and less likely to have a syrinx, but there are exceptions to all of that. The natural history of Chiari, when it's asymptomatic or minimally symptomatic, is good. The first paper, very small series from Italy, 22 patients, a larger series from Miami, 124 patients, and then this was our series, 150 patients. So you choose not to operate on somebody who either has no symptoms or very minimal symptoms and don't want surgery. And in general, that population has a good outcome if you follow them for many years. What about the tonsil position? Does that change over time? Well, we're looking at another one of these bell curves. The answer is, in general, it doesn't change over time. However, there are examples of people getting a little better or a little worse, or in very rare instances, people getting a lot better or a lot worse over time. When we look at age as a factor for this change, it tends to be the first decade of life where we see the vast majority of these changes. And if you're into your adult years, in general, it doesn't change that dramatically, except for a very gradual rise over the decades. If you're somebody that doesn't have a Chiari at all as an adult, and then all of a sudden you have a Chiari, you probably have a CSF leak. So here's just some examples of kids that essentially grew out of their Chiari. This is the same patient, left and right. Chiari on the left, no Chiari on the right. Another example here of tonsils getting better. So going back to this 5 millimeter idea and looking at our own data on who is symptomatic and who's not, I would say that 5 millimeters is certainly not 100% specific. It's about 10% or less specific for symptomatic Chiari malformation. If you get a full centimeter below the foramen magnum, now it's about 1 out of 3 of people that are coming in to the neurosurgical office. So what does tonsil position mean? It's not an absolute cut point. Right? We can't think of Chiari malformation like we think of certain other diseases. Like there's the old joke, you can't be a little pregnant. You either are pregnant or you're not pregnant. Chiari is nothing like that, right? We have this measurement that we make in the human body with a bell curve distribution, and we have chosen to label people that are 5 millimeters below as having something called Chiari malformation, right? But that's a relatively arbitrary cut point that we have. So we need to be a lot more nuanced in our understanding of these people and these patients. It's like, what are your symptoms like, right? Because the lower your tonsils, the more likely you are to have symptoms that we associate with Chiari malformation, more likely you are to benefit from surgery. But it's not like a cut point that's absolute between a diseased population and a healthy population. Okay, so now what about lifestyle decisions with Chiari malformation? I'll tell you about 2 questions I get. First most common question I get in my pediatric practice, the second most common I get in my adult practice. So for kids, the parents always ask, can we play sports? In adults, the women always ask, can I get pregnant? Right? So we're going to address those one at a time. In the old days, or not so old days, here's 2002, people discouraged kids that had Chiari malformation from playing sports. Here's a very well-respected group of neurosurgery trauma experts, Bales and Cantu, that generally recommend against returning to contact sports. Here's another very well-respected neurosurgeon, 2008, recommend avoiding contact sports. So it has been controversial to allow kids with Chiari malformation to participate in sports. So why is that? Well, because there have been a handful of reports of kids with Chiari malformation that participate in sports and get very badly injured. Okay, here's a review article where they looked through the world literature at all of the case reports of this eventuality. They found 17 cases of acute neurological symptoms or death following trauma, not just sports trauma, any trauma in people with Chiari malformation. So that's obviously really, really unfortunate for those 17 individuals. But Chiari malformation on imaging is really, really, really common. So finding 17 cases of individuals that have been injured with Chiari malformation does not move the needle statistically. I would argue you're looking through the wrong end of the telescope. You're starting with a very rare thing. You're accumulating examples of this rare thing, and you're extrapolating that in a way that doesn't make sense. So there's two articles, three now. We've written 2 articles, and the Boston group has written an article on Chiari athletes and what their risk is. And in every case, these papers have not found a substantially increased risk for the athletes with Chiari versus normal athletes. So the Boston group had 147 patients, mostly teenagers, over 1,600 athletic seasons, and they didn't find any examples of permanent injury, death, coma, or paralysis in the Chiari patients. That's always been our practice too. I've always been permissive with respect to sports for people who want to play with Chiari malformation. And so after years and years and years of being permissive, we said, okay, how are we doing? Is this okay? And it turns out it is okay. This is an article we wrote, I think it was just published almost 2 years ago now, where we had 470 odd patients with Chiari malformation, about 13 years of age. We followed them on average for a couple of years. And you can see that the sports that they were participating in here. So a lot of non-contact sports, but an awful lot of contact sports too. If you look at the tallest bars, it's football, basketball, and soccer for boys. And same thing that we talked about before. There is no increased risk of sports injury in patients with Chiari versus patients without Chiari. We found the expected rate of concussions that we would find in any normal population. There were no permanent injuries. There was one transient injury in this patient who didn't really have much of a Chiari, I would argue, and had transient numbness and weakness while playing soccer that resolved. I would argue that that was what we would call a spinal cord stinger, unrelated to the Chiari. So my practice has not changed on the basis of these data. I let people play. The trouble with this is we're proving a negative. And I think if you want to be cynical about this, this is like people in the 1950s saying cigarette smoking is safe, right? Because you didn't study a large enough group of people. And maybe eventually, if you study 1 million people, we can find a difference. But the counter argument to that is, if we got to study that many people to find a difference, this effect is small. And I think that sports participation is valuable. So I'm going to let my kids play. There are, if you Google search this issue, though, this is what you find. You find a lot of law firms that are willing to take these cases on, people who have Chiari malformation and were hurt after trauma. So this is the struggle that I think we face as medical practitioners sometimes. Is I believe the data are telling me that this is safe for kids, but yet this is also out there too. So we have to be aware of that. So now the adult problem. This is the number one question I get in my adult clinic. For patients with Chiari malformation is, can I have a baby? What should I tell the obstetrics or the anesthesia team? What special precautions do I need to take? Well, when I first started getting asked that question, I really had no scientific answer that I could offer. So we decided to study the question, and we looked at a large national data set. It was that Optum data set, the first one I showed you, with the increasing rate of Chiari diagnosis over the years. Has gone up 3 times in the last 25 years. Well, same data set now. So we had almost 60 million privately insured patients that we studied. So everybody in this data set has insurance. These decisions are not being made because you have insurance or don't have insurance. Everybody has access to insurance and healthcare in this data set. And we asked the data set who has a Chiari malformation, who's having a baby. And then we looked at the obstetrical outcomes in the different circumstances. And number one graph on the left, you can see, not surprisingly, increasing numbers of women with Chiari are having babies. That's just because more people know they have a Chiari now than before. And I think this is interesting. If you look at who's having a C-section with their delivery and who's not, Over the last 10 years, you can see in the red bar, the Chiari moms are much more likely to have a C-section than the non-Chiari moms. It used to be a mixed bag, but now very consistently for 10 years, we've seen that if you have a Chiari, you're more likely to have a C-section. Same thing over the same period of time, last 10 years or so, if you have a Chiari, you're much less likely to have an epidural anesthetic than before. So having a Chiari is changing obstetrical and anesthesia practice. People are being advised to have C-sections. People are being advised not to have epidurals. Now, does that make any sense? Is there an evidentiary basis for that? I would argue not. We looked at 400 patients with Chiari diagnosed before the delivery, 648 patients with Chiari diagnosed after the delivery, for 1,000 Chiari patients total, and then we compared them to people without Chiari malformation. The bottom line is there's no increased risk of bad maternal outcome with Chiari malformation. And that's a very large N, I would argue. So again, when patients come to see me and they ask, what should I tell the obstetrician? What should I tell the anesthesia team? I say, you know what? Follow best obstetrical practices, right? Whatever is best for you and your baby, that's what you need to do. You need to put the Chiari out of your mind. So what about Chiari surgery? Who's having Chiari surgery? You can see, this is another one of our papers from a few years ago. Black bars are kids, the white dots are adults. There's an increasing rate of Chiari surgery in the United States, especially for pediatrics. It's true for adults too, but to a lesser extent. In general, when you're looking at predictive factors for who's getting Chiari surgery versus who's not getting Chiari surgery, I think it's interesting that actually wealthy households are much more likely to have Chiari surgery for their children. But that's not true for adults. The opposite is true for adults. Poorer households are more likely to have Chiari surgery as adults. These are all insured patients. So this is not because some people have insurance and some people don't. This is taking that into account. And then the other thing that I think is really interesting is there's a very important geographical difference. Where you live in the United States is very predictive over whether you're going to have Chiari surgery or not. So we're here in the Pacific, just sort of in the middle of this graph. We're actually the region of the country that has the lowest rate per capita of Chiari surgery. If you live in some other parts of the country, east, south, central, east, north, central, you're much more likely, almost twice as likely to have Chiari surgery. And this is true for a lot of types of neurosurgical procedures. Like for instance, if we look at spine surgery, disc surgery, instrumentation of the spine, we'll find similar geographic differences. So who should get surgery? I've already talked about the MRI appearance and how I don't think that 5 millimeter rule should be absolute. I care a lot about the deformation of the tonsils, how much space there is at the foramen magnum. We did a study a few years ago where we said, okay, if we don't believe in tonsil position and that's not a good indicator for who's going to do well with Chiari surgery, what is? And we measured all these other lines in a very large population of people with classic Chiari symptoms. And we compared that to other people with a Chiari that were classically asymptomatic. And we said, are any of these things predictive for having symptomatic Chiari? Measured these lines as well. We also did 3D modeling of the posterior fossa, both the whole posterior fossa as well as the inferior posterior fossa. And here's the bottom line. None of these things made any difference. We used computer learning the first time, and the computer learned on that group of 200 patients that we had and spit out this formula that was 100% predictive of symptomatic Chiari. And I was like, oh my gosh, we solved the problem. Now I can just plug that formula into all the new patients I meet. But guess what? When we studied it on a similar size group of new patients, it was worthless. Once a year, I'm asked to review a paper where somebody basically does this study without trying it on a new group, and I'm like, it's just not going to work. Try it on your new group and then send it in if it works. But so far, it's never worked, not for me, not for anybody. What about symptoms? Well, symptoms are really important. That's the most important question with respect to who should have surgery. The thing we have to be careful with is Chiari on MRI is really, really, really common, right? About 2% of kids, 1% of all patients getting MRI scans. So when we're looking at symptoms and we're asking, a headache is the most common Chiari symptom, and that's really common, we got to be careful that there's going to be some coincidental overlap of a really common MRI finding and a really common patient symptom. So we operate when we think the symptom is cause and effect with the Chiari, but not when we think you have a Chiari and you have a headache, but you have no relationship with the two. So we have to try to sort that out very carefully. Again, headache, really, really common. 8 or 9% of kids, some papers reporting even as high as 20% of kids. So only certain kinds of headaches are going to be a good reason to do Chiari surgery. Well, what kind of headaches? Here's the International Headache Society's definition of a Chiari headache. I think that this is all, for the most part, correct. When you have a short headache, less than 5 minutes, it's in the occipital area, back of the head area, and it's brought on by valsalvas, coughing, sneezing, straining, that's a Chiari headache. Perfect. We all agree about that. The trouble is that it's never that simple, right? I guess sometimes it's that simple, but more often you have some features like that and you have some features that aren't like that. They last a little longer. They're not always in the back. And so on. And then you have to, that's a judgment call, right? But for me, I do try to figure out how close to that description is the Chiari patient. This next part from the IHS is not particularly helpful. They said Chiari headache is a headache that gets better after Chiari surgery. Well, yeah, sure, but we're not going to operate on everybody just to find out. So for me, I want to know how typical are your symptoms and how severe are your symptoms, right? And if you have typical and severe symptoms, that's a great candidate for surgery. We're going to help that person. If you have typical symptoms and I ask you, does this headache change your life? Is it bothering you? And they say, no, I don't care about my headache at all. Well, it's somebody who probably shouldn't have surgery, right? It's not bothering them enough. It's not enough to go through the ordeal of surgery. So I want to see typical symptoms and I want to see severe or life-changing symptoms. And then I won't say much about this, but again, very common finding on MRI, so we have to be careful. Here's a list of symptoms that people have attributed to Chiari malformation, and I think that there's some evidence for some of it, a lot of, not very much evidence for a lot of it, but we have to be very careful. Symptoms have to be specific if we as surgeons are going to advise for surgery. What about Syringomyelia? Syringomyelia is absolutely a good reason to do Chiari surgery. And we say that because we know the natural history of large cervical Syringomyelia is not good. When people develop a large cervical syrinx and it's not treated, they will, in most cases, eventually start to develop symptoms, usually pain symptoms, sometimes weakness symptoms, and it's very hard to put that genie back in the bottle and fix those symptoms after they've started to develop. So when we meet somebody, even an asymptomatic individual with a large cervical syrinx, I usually advise for surgery, a so-called prophylactic surgery, to reverse that syrinx, shrink the syrinx down, and make sure that they don't develop symptoms. So these individuals that I'm showing you here, regardless of symptomatic state, I would recommend surgery, but not this individual. This third individual that I'm showing you here, this patient has some syrinx that's different. It's smaller and it's lower down in the spine, in the thoracic spine. And for me, that's a syrinx with a different natural history. It doesn't share that dismal natural history that the large cervical syrinxes have, and I don't use that image as an indication for surgery, and even less so here. There's a debate about whether to even call that a syrinx. Some radiologists will call it a syrinx, some will not. The bottom line is it's not of significance with respect to surgical decision making. Here's an article we wrote a few years ago. I looked at all syrinxes in our large data set, and I stratified them by whether they were in a patient with a Chiari malformation, which is here, this is Chiari 1, Chiari 0, and so on, or whether they had a syrinx for some other reason, so tethered cord, idiopathic, that sort of thing. And we looked at the characteristics of the syrinx, and the Chiari syrinxes were wider, so higher up the y-axis is wide. The idiopathic ones, tethered cord ones, were skinnier. Then we did the same thing. We looked at those two different groups, the Chiari groups here, the idiopathic or tethered cord here, according to whether they were up near the top of the spine, which is the ones farther to the left, or down towards the bottom of the spine, towards the right. And the Chiari were up towards the top. In other words, they were in the cervical spine. The idiopathic tethered cord were generally lower. So just taking those two pieces of information, how wide is the syrinx and where is the syrinx located, and we combine them on one graph. Here, the Chiari is in red, the idiopathic or tethered cord is in blue. All of these patients have syrinxes, but I would argue they have two different kinds of syrinxes, which we can separate into two different populations with admittedly some overlap. But when a patient is over here, skinny syrinx, not cervical, then I can't make a cause and effect relationship between that patient's syrinx and the Chiari. That's not a surgical indication for me. When they're over here, then yeah, I think the evidence speaks to a cause and effect relationship, and I'll operate on that patient. So Chiari is associated with syrinx, but there's exceptions. Not all Chiari patients have a syrinx, not all syrinx patients have a Chiari, and most importantly, not all patients with a Chiari and a syrinx have a Chiari-caused syrinx, and I think that's important for deciding who to recommend needs prophylactic surgery. And then the final point I'll make is, what about scoliosis? We get this all the time, especially in our younger patients. A patient has scoliosis, an orthopedic surgeon sends them for an MRI, now they have a Chiari malformation. Should we operate on that Chiari if the scoliosis is the one and only presenting factor? And I think the answer is really clear, that when the patient has a Chiari and a big syrinx and scoliosis, that we should operate on the Chiari, because we know Chiari causes syrinx and we know syrinx causes scoliosis, right? The question is, what about if there's no syrinx? What if it's just the Chiari and the scoliosis? Does that patient get surgery? We looked at that in a paper a few years ago. We looked at everyone on our data set that had Chiari, everyone who had scoliosis, everybody who had Syringomyelia. Not everybody all had the same, all three. Some only had one, some had two of those three, some had three out of those three. And we looked at them to see if there was a relationship. And yeah, having a Chiari is extremely symptomatic, is extremely predictive of having scoliosis. A very strong correlation between Chiari and scoliosis. And for those of you in the audience that don't speak statistics, a p-value of less than 0.1 is considered very significant. You can see there's a 0.0001. So a very significant relationship between scoliosis and Chiari. The trouble is, when we do a so-called multivariate analysis, when we say, okay, well, we're not just asking, is Chiari associated with scoliosis? We're saying, is Chiari without Syringomyelia associated with scoliosis? And that there, it completely drops out. Chiari is not related anymore. So for me, now on the basis of this, when I see a patient that has Chiari but no syrinx and scoliosis, unless there's some other reason for me to do that Chiari operation, I don't recommend that Chiari operation. And this has been, I think, supported by also now the Boston group that looked at 32 patients in their series and came to the same conclusions. So again, I'm not going to do it in that second case. So 3 surgical indications for me in my Chiari practice. Anatomical findings of a Chiari, and again, not so much interested in the 5mm rule, looking at the tightness of the foramen magnum, with severe classic headaches or typical enough symptoms. And I try to put people on a spectrum. Is it the most classic? Is it not classic at all? Or somewhere in the middle? And on the basis of that, we have a conversation about what the likely outcomes could be, how likely it is that somebody's going to get better. The more classic, the more likely. The less classic, the less likely. But we can still always have that conversation. Anatomical findings of a Chiari with a large cervical syrinx, that's a surgical candidate for me. And then scoliosis if there's a syrinx as well. So this is my last slide. Just to reiterate the main points of this little introduction to Chiari. There's no consensus about how to define Chiari. I think that the 5mm rule is seriously flawed, but we all need to still start our discussion of Chiari with that point. Symptomatic Chiari is actually relatively rare, but asymptomatic Chiari in imaging is extremely common. Symptoms in syrinxes or syringes, if you prefer the Greek, are more likely with increasingly low tonsil position. So tonsil position does matter, and the lower your tonsils are, the more likely you are to have symptoms, the more likely you are to have a syrinx. Patients with typical and severe symptoms will benefit from surgery in most cases. It's a great operation when you're doing it for the right patients, for the patients who need the operation. And the natural history for patients who don't have symptoms or who have minimal symptoms is actually very good in most cases. So first do no harm.